May I ask if this microphone is functioning? Sounds like it is to me. I believe I must be kicking off at the end of a break because I saw lots of folks in the exhibit hall, but you're not here to see what I have to say, so I'll just say what I have to say in introducing Eric Dishman and then step aside. So my name's David Torchiana. I'm the head of the Partners Healthcare System from which this symposium emanates. And I'm very pleased to introduce our next speaker, Eric Dishman. Eric is the head of Health and Life Sciences, the Health and Life Sciences group at Intel, and he's focused on how new technology can help solve the big healthcare problems that we all face. He's best known for his work on home and community-based technologies and services that can enable independent living for seniors, and for this was named in 2008 by the Wall Street Journal as one of 12 people who are changing your retirement. Throughout his career, Eric has challenged us to move away from the idea that healthcare has to be delivered in the traditional face-to-face manner, to make healthcare more of a team sport and to take advantage of technology to achieve this evolution. I know I will. I think you all will enjoy his perspective. Welcome, Eric, to the podium.
Great. Thank you so much. Well, good morning. It's great to be here. I'm actually, for once, I've been here before. For the last 2 years, I was not reliable. I was recovering from a kidney transplant and dealing with sort of rejection issues and all of that. And I told Joe, I said, I don't care if I have to be medevaced in. I'm not going to miss your conference this year. I'm really healthy today. Everything's good. So it's really great to be here. I'm going to talk about a little different topic than I have sometimes spoken about here. I do tend to talk about aging in place and independent living, but I actually want to talk a little bit about collaborative cancer care and genomics. And my basic argument here is we are not going to achieve precision health and precision care if we don't make it unbelievably connected care. And I'll give you some examples of that. Now, this is a slide that I've probably shown in talks and keynotes for 25 years, or, well, no, at least 20. I drew this on a napkin one day for Andy Grove, and I said, conceptually, what we need to do in healthcare is, here you've got the vertical axis of quality of life and this horizontal axis of estimated cost of care per day. And I said, conceptually, none of us want to be down in that bottom right in the ICU. I have spent a whole lot of time in ICUs, and I'm really working hard to get out of them as quickly as possible. We want to be at home and in the community where your quality of life is high, your cost of care per day is low, and the level of expertise required to help you with your care is quite low. So our whole philosophy for 2 decades now about the internal investments that we make, the external investments that we make, we call shift left. Either shift left or stay left, and what's the role that technology can play in that? So we call this personal health. Everybody's now using the phrase precision medicine. It's not just about medicine, so I'm willing to say, okay, we're going to shift from this mainframe healthcare paradigm to a precision healthcare paradigm. And there's 3 primary capabilities technologically that we're investing in and working on and trying to build open platforms on to enable the world to do. Connected, distributed, and personalized care. Right? How do we connect all the players in every way, shape, and form and develop collaborative care teams? How do we enable distributed care to occur in the home, in the workplace, increasingly not in large megaplexes hospitals, only use those when that's the right tool for the job, and then personalized care. And today I'm going to focus a lot on genomics, but in personalized care we mean things broadly. From our pilots that we did 15 years ago with wearables and early smartphones to try to help prompt people to take their meds at the right time and learn things like, hey, the right voice tone that you actually use, if you put it in Oprah's voice, a segment of the population will comply with that more than the computer voice. But for others, they want to be reminded on their phone or a beacon or their television interrupted, right? That's an example of personalized care as well, enabled by technology, where you can customize the sort of treatment plan and the behavior change onto the platforms that people are comfortable with in ways and styles that really fit their personality. But I am going to talk a bit about the personalized care today from a genomics perspective specifically. Now, this is basically learnings from a lucky guy in the 1% Club. I attended the panel last hour with different patients sharing their experiences and then how they had translated those experiences into impacting other people because they were lucky enough for themselves or their children to survive. So I'm just going to kind of do the same thing here, but I'm going to put it in the context of some work that we're doing at Intel. And when I say I'm a lucky guy in the 1%, I actually mean 3 versions of the 1%. The 1% of cancer patients who have actually had a whole genome sequence that could become part of their care. The 1% in terms of the economic 1%, where I was able to access that primarily because of my position as an executive at Intel, knowing the right leaders, knowing the right senators, and having the financial means to sort of make things happen for myself and collect my own data. And I also mean the 1% of patients who are really proactive at the level of owning their own data and putting it into the world. Those are 3 1% clubs that I don't really want to be in. I want them to be much larger for many more other people here. So if I give you the context of this is me in my freshman year in college in Chapel Hill, North Carolina, or sophomore year, actually. I had been diagnosed with cancer about 6 weeks before this. I was now 2 weeks into chemotherapy. I was not responding well. I weighed about 100 pounds my sophomore year in college, and as I got on the cisplatinum, I started losing about 20 pounds right away. So I was pretty tiny. My wife knew, she's like, he's not going to survive this drug if I don't get him a puppy. So this was the new puppy that she had actually gotten me. I also look at that furniture and think, I used lawn mowing money and bookstore money to actually pay for that furniture because I thought it was attractive at the time. And when I say I'm the $6 million man, now what happened the day that I got diagnosed, there were 2 doctors, oncologists, arguing in front of me, and one of them thought that I had something that was sort of like a childhood kidney tumor, like Wilms tumor, even though it didn't present like that exactly. And the other thought that I actually had something more like renal cell carcinoma, clear and transition cell, and it didn't look exactly like that either. And they're arguing in front of me, but then they give me the definitive diagnosis because one of them wins the argument. And I remember they were going back and forth, and one's like, don't treat him like an old coot, he's only 19. And the other guy's like, don't treat him like a kid, he's only, he's 19. And they just could not figure out what diagnostics code box to put me into. And this began 23 years where I was never cancer-free of more than 24 rounds of chemotherapy, radiation, and immunotherapy. I remember, Time magazine would come out and talk about interferon. It's like, no, that didn't do it. And then interleukin, God, that almost killed me. And I somehow kept surviving the sort of well-intentioned guesswork that was being used to sort of drive my care, with 72 different diagnosis codes becoming the definitive diagnosis over that period of time. And for the first while, they're saying you have a year to live, but when I reached the first decade, I was like, just stop saying this stuff. I'm going to live much longer than any of you can anticipate. I'm working on an article, and an economist is helping me to actually calculate, and I'm writing a book about this whole experience. So we've been trying to calculate the cost. Our early estimate, and this is not in modern dollars, is the cost of that imprecision medicine, where we're sort of may as well have flipped a coin, or done the roulette wheel to figure out what treatment I should have used, or gotten Curious George to actually figure out how to cure for me. And I don't mean this in a derogatory way. This was all well-intentioned care, but it was guesswork. The cost of that care was at least $6 million. Right? And it really was the cost of imprecision medicine. I mean, there's certainly the cost on me and my family and the weight of all of that, but in terms of the cost of care, and when we put it in today's dollars, it's going to be a much larger number than that. We simply can't afford, as a society, the cost of imprecision care. The suffering costs, the financial costs, and we have to develop the skills to drive precision. So, and we also can't take the treatment time for imprecision medicine to take 23 years. And cost $6 million. At the end of all of this, my last business trip for Intel, because I was in full kidney failure, both kidneys were now gone with cancer, had not yet started dialysis, and lived in full kidney failure, working full-time at Intel for about 3 years, but it was finally getting so bad. My last trip was to Boston and San Diego before I was not going to be able to travel anymore, and I was going to have to start dialysis, and then the maintenance chemotherapies that seemed to at least keep me somewhat stable, I couldn't stay on anymore because the machines couldn't filter it out. So one of these trips I go to, and this guy is like, hey, we were visiting startups who were trying to do genomics. They needed Intel's compute power, right? They're like, oh, our business model's not going to be possible for 8 more years because we just don't have enough affordable compute speed. So we go in and actually help them. One of these guys at these startups saw me, and he's like, did you give a talk at a kidney cancer conference years ago? And I was like, yeah, that was me. And he's like, yeah, everybody still remembers that, because I had brought my scans and slides and be like, hey, anybody know what to do with these tumors? Nobody else seems to. But at the end of this, he's like, hey, why don't we sequence you? I'm not trained as a biologist, and I'm not a technologist. I'm a social scientist who runs Intel's health and technology business. So I'm like, yeah, you can sequence my whole genome. It'll help me understand your technology. I did sign some forms that said you could actually give this to my doctors. Fast forward about 6 or 7 months, And I go in for my routine appointment, which was 3 times a week because I was so ill. I was still trying to not be on dialysis, but they were doing other things to just try to keep me functional. And multiple of my doctors are there in person and some on video conference. And I'm like, this is not good. This is like the day I was diagnosed. It's the only time you ever show up is when you got bad news all in the same place. And they said, hey, Eric, we have bad news and good news. We think 92% of what we ever put you on was destined never to have worked. But the good news is we've been spending 6 months trying to make sense of your whole genome sequence. They had never done it before, most of them, having to work with companies and research labs, some of them here in Boston, to make sense of it. And they said, we think we know what to put you on. And they put me on a pancreatic cancer drug, even though my pancreas is fine. And then 3.5 months later of a not bad chemo round, I was totally fine, cancer-free. And they're like, you're eligible for a kidney transplant, which I'd never even Googled. And an Intel employee donated it to me, and 3 years ago, almost, on my anniversary, I'm cancer-free, I'm incredibly healthy, and I came back to Intel and said, that miraculous whole genome sequence that I had, we have to scale that to everybody. So let me tell you a little bit about what we're doing to try to make that happen today. The compute time for me 5 years ago when we did this took 3 months to process my genome and my healthy genome and my cancer genome. That's unacceptable. That's not going to scale. And it took 4 months of them FedExing, phoning. When I first got it, they sent me my data because I'm such insistent. And 5 1-terabyte hard drives actually showed up at my house. I'm like, great, not sure what to do with that, right? And that's what they had to do to share data back and forth across the country. These files are not going to be moved through a network. They're not going to be put all in one large cloud when they're a terabyte file each time you actually go in, right? So 4 months of them trying to find other people that looked phenotypically and genotypically somewhat like me to sort of guess what we might do, and to go through chemistry databases to say, hey, what chemistry might deal with the mechanism that we think we now understand a little bit more about as cancer, not just the location of where it happened to be. And all of that ended well. The problem is less than 1% of people are actually sequenced today with cancer. And with all the other diseases, most folks are still in trial and error treatment, well-intentioned guesswork, sometimes with more science behind it, sometimes not, but this is the paradigm. If we're going to talk about the President's Precision Medicine Initiative, which I worked on and am very supportive of, we have to admit and have a conversation with society that says we're living in an era of imprecision medicine now, which is not going to be comfortable for people. But less than 1% of cancer patients sequenced. If you generate 1 terabyte of data per patient, roughly, to whole genome sequence them just once, that's basically for the new cancer patients each year. If we just sequence them once, that's 1.65 million new cancer patients in the United States with a diagnosis. That will generate 4 exabytes of data. Now, 5 exabytes of data is the estimate of what the entire canon of written in human words ever spoken and thought by humans written down would be. This would take, we calculated this, 1,500 million server hours and an annual power bill of $53 million just to process the sequencing. That does not scale. So this is an enormous challenge. And that's just cancer, just the new people in the United States, right? So now think about trying to scale the analytics and the data capacity of precision medicine, precision health for the wide range of other diseases that we hope, if we can make the knowledge turns go faster, there's going to be breakthroughs in as we go forward. So these are the kinds of steps. I was just at the Broad yesterday. I got to be in the room where the whole genome, the human genome, was first sequenced. And they really went through the process for me about, hey, Eric, from your blood work that we took, here's how it went, right? And directionally with the cancer centers that we work with around the world at Intel, it still takes 1 to 4 days to actually just do the sequencing, right? And prepare the sample, get the sequencing done. So now you've got your billions of base pairs laid out in a map. And then it can take weeks to do the secondary analysis through a wide range of complicated tools, trying to figure out what's your sort of variant or mutation list. And then it can still take months to go try to find other people that look genotypically like you to figure out, hey, what worked for this person that we might target specifically for this person, and to walk through all of the databases that exist. Think of all the failed drugs through clinical trials, but may have a chemistry that could be very helpful for the particular mechanism that's going on with you. This is looking for a needle in a haystack that's not all in one place, and it's being done primarily via phone, faxes, and FedExing disks around, right? That's not a scalable, sustainable thing. So our goal at Intel is not us alone, but to create an ecosystem in biotech that says we can do all of this in one day by 2020. If this has taken months now, could we get to the point where your clinician could walk in the morning and take the sample, they do the sequence, they come up with your mutation list, and compare that to all the known chemistry databases and all of the known databases about patients, and compare it and say, hey, by the evening, we've got a custom treatment plan for you. Right now, we think this may take until 2035, but we think if the ecosystem worked together around standards and accelerating these kinds of things and standardizing workflow and tools, we could get there much faster. And it's important that we do. And here's part of the problem. If you think about cancer, Intel's been involved in these. There's public data sets that we're creating where we're putting people's genomic data for cancer all in a cloud somewhere, de-identified, so researchers can move forward. That represents only 4% of the data today. Right? 4% of the knowledge about the data about cancer patients is accessible to research today, because the vast majority of it is in the data centers, the private data centers of the cancer centers and the hospitals and clinics who are treating the patients. And you can't move all of that data to one place. So 96, what's below the iceberg here is that data is stuck in medical institutions. It's too large to move, and it's protected by privacy laws and other kinds of business model IP where people don't want to share that data for some legitimate reasons and also for some that are not so legitimate. It's like, how do we, if you're not going to find somebody like me, I mean, if you go to the largest cancer centers in the United States, none of them represent more than about 1% of the total cancer data for the United States, right? When we're talking about the kinds of analytics that's going to need to happen here, you need a large common denominator of data to be able to figure out, how do I develop a precision custom treatment for you? So this is where we've been focusing. We've developed something called the Collaborative Cancer Cloud. This is a partnership with Oregon Health and Science University, and in Q1 we'll announce 2 other cancer centers that are using this. And the whole premise here is send the analytics to the data. Do not get into a paradigm of trying to copy-paste the data. So for example, if I'm a clinician that actually wants to find somebody else like Eric, it creates a secure container. I'm sitting at OHSU and my oncologist actually wants to send it off and has done the sequencing, and here's the profile of Eric, sends it off to the others. They're authorized to come into that environment. That's not copying the data over. That secure container goes to here, 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 and here, and these other cancer centers, and it's the query saying, anybody else got anybody like this guy? And then it sends the results, de-identified, and the connection to the clinicians who are there, and they could actually make a call and say, hey, we found somebody by doing this distributed secure sharing of search, not the data itself across all of these sites. So that's our goal, and that's what we've been focused on. But the other piece of it is, so we want to connect all of the players who are treating people with cancer and make it finally possible for them to securely share. And these will be open source tools that we'll start to launch in Q1. But we also want to make sure that we have a connected cancer patient, right? I mean, for me, I can tell you that cancer is never done. I still have to monitor my new kidney health. My old ones, that picture's funny. My old ones don't exist anymore. I'm dealing with neuropathy. I'm dealing with cognitive challenges and dealing with follow-up from cardiotoxicity of all of those. So today, I still have 12 clinicians, 7 web-based apps and portals, 9 personal devices that remain disconnected, proprietary, and resistant to me owning my own health data. So we've got to get out of these attitudes that are keeping us from actually sharing data. And they basically, in my last slide, boil down to this. We are still struggling with barriers, whether it's connecting the cancer centers or the data that I want as a patient. We're still uninteroperable, and sometimes it's intentional. The lack of common APIs, logins, and UIs. The my data is their business model problem, right? The vendors and sometimes the providers are more focused on monetizing my patient data than making it available to me. On the security side, there are so many people hiding behind HIPAA as an excuse about why they cannot give us our data. That's appalling, and it's sometimes actual policies, and sometimes it's just misperceptions. And finally, we are still struggling with the infantilism and risk wariness of clinicians in many places. There's been progress, but we have to admit that there's still widespread belief that patients don't know how to use their raw data. Stop just giving me summaries. I'm the only one that's going to find the clinical trial I need to be on safely. So connect the players, connect the patients, let's deal with some of these barriers, and I think we can make all in one day by 2020 happen. Thanks very much.